Brenda Williams is going to do our STEMmer report for us.
Thank you. Good morning.
Good morning.
I gotta remember how to do all this, all these gadgets. I'll move to the first one, get started with our EMS report. So this EMS report, the call was received at 1800, 67-year-old male complaining of chest pain. By 1825, they arrived at the patient. The patient was sitting in the living room chair. He reported he was at rest. He was having sudden onset of chest pain that radiated to his right arm. He became diaphoretic and very nauseated. Nausea gone by the time of arrival, though. Still rating chest pain as an 8 out of 10. He had a history of non-insulin dependent diabetes and hypertension. By 1842, vital signs were obtained. 145 over 85, a heart rate of 56, respirations of 18, 97% on room air, blood sugar of 150. His pain was still 8 out of 10, and a 4-lead obtained was showing sinus Brady. 1845, they got an 18 gauge to his left forearm and administered 324 milligrams of aspirin. From 1852 to 1903, they had given 3 sublingual 0.4 milligram nitro tabs, and they also administered nitro paste 1 inch with improvement. They also put on 2 liters of O2 nasal cannula due to him dropping to 94%. Now, 1922, and you'll notice it's bolded, they put, this was the time on the report, transport report, 12 lead obtained, ST elevation in V2 through V4 with reciprocal changes in lead 3 and AVF. I question whether that time is correct, and we do watch those. So please be careful when you guys are making out your reports that you're putting down the exact time, and I'll show you why. Because at 1923, he arrived and was transferred to care to Union Hospital. So I can't imagine they got the EKG at 1922 and arrived in 1923. So that was how it was reported. So I just wanted to make sure. What's that? It may have just been a serial EKG, not their initial. Okay, yeah. It's just we watch those times. So yeah, we need to have that reported correctly. So he arrived again at 1923 and transferred care to Union ED. He got down to the cath lab and a balloon across the lesion by 2053. And a successful cutaneous coronary intervention, or PCI, of the proximal mid-left anterior descending artery with 2 drug-eluting stents due to the lesion was a length of 30+ millimeters. It went from 100% occlusion to 0 residual stenosis. I know those times look pretty long, but if you'll notice, it was exactly 90 minutes from door to balloon time. And that's what we're looking at. I mean, yeah, 1 more minute, we did overtime, but it was perfect. And this guy had a lot going on. So they did apply a TR band at the procedure completion. His pre-hospital EKG to balloon time was 91 minutes, again for that same 1922, is the only one reported. Door to balloon was 90 minutes. Patient was admitted to ICU and started on a high-intensity statin. His diabetes was evaluated to optimize his medical therapy. Because they went on to use a TR band, I wanted to give a little bit more information about our TR band use. So here's a little bit about the pros and the cons of doing the femoral versus the radial angioplasty. You'll see the pros with the femoral. Long history of success. I've been doing it since 1960s. More doctors are trained and experienced in this approach, and most of our cardiologists do this way. Better for patients with extensive peripheral artery disease. Of course, the cons, you'll see there's a longer list of those than for radial angioplasty. You must lay flat for 4 to 6 hours after procedure. So I'm the manager of 2 West. We get a lot of these patients, get a lot of fight from these patients who don't want to lay flat and are not told this originally in the office. So you can imagine with a TR band, there's not that having to lay flat for so long. Lengthy compression process that requires the nurse. And of course, she has to hold pressure for 20 minutes after pulling the line. And if there happens to be a hematoma, they start the process over and hold pressure for a while. Of course, the risk of bleeding. It can be difficult to reach the artery to perform the procedure, and if necessary, stop any bleeding, especially if the patient is obese. And the femoral artery is the only source of blood to the leg. Granted, with the transradial or the radial angioplasty, history of success, it was first used in 1980. Reduces risk of bleeding, important consideration for women, elderly, and people taking blood thinning medications. Less discomfort. Do not have to lie flat again for hours. Can move around as soon as effects of the anesthesia has worn off. Can eat and drink soon after the procedure. And the radial artery is not the only source of blood to the hand, as in the situation with the femoral. The procedure, the cons, the procedure is technically more difficult than the femoral approach because the radial artery is smaller. Not as many doctors are trained and experienced with this approach, but I will tell you we have several cardiologists doing this now here, both PNG and UAP. So it's been great. We've seen a lot of success with it. So I just thought it'd be interesting to let you know how far we've come. Next slide, I'll just show you a little bit what it looks like. There's the TR band structure. You can see where it's like a little balloon and then the nurses come along, and every 5 minutes they take air out for the first 20 minutes or so. If they would start to see bleeding, once they start to let the air out, they have to put the air back in, wait a few minutes, come back and try it again. The course of action is to have it off by 2 hours after they've come to the floor. So you can see where this is a lot less time needed to, to not holding the pressure for 20 minutes to the groin. So it's just a better process altogether. Our next slide, I wanted to show you our door to balloons within 90 minutes are still at 100%. So we've been 100% for the whole year. So it's been a great run. And thank you for all that you do.
Thanks, Brenda. Anybody have any questions for Brenda? Next, Deb Harden's going to come and say a few words. We always have her come in the December meeting just to say hello and.
Thank you, Barry.
Thank you.
Hi, everybody. It's so nice to see you all, not in the ER. Calm, right? So thank you for having me come. This is one of my favorite things to do, is to come and talk with you and bless your meal. So I was thinking this weekend, I went to see the Mr. Rogers movie, and I don't know if any of you have seen it or not. I don't often recommend movies, but this one I do recommend. It's really more of an adult movie than a kid movie. And in that movie, there is a scene where he is talking to a journalist that his story, the journalist's story, is woven into Mr. Rogers' story. But there's a scene where they're eating, and Mr. Rogers is asking this young man about his father. And they have a very rocky relationship. And so the journalist doesn't want to talk about his father. So there's very strained silence. So Mr. Rogers says to this young man, I want you to think for 1 minute about all the people, including your father, who helped you become who you are. And so they do that. And Mr. Rogers thanks him. They don't say it out loud. They just think about it. And so I was thinking about that, and I was thinking, my husband and I said, we should do that when we get home. And so I was thinking about all the people that helped me become and continue to help me become who I am. And in some measure, it's all of you. Because of what you do and getting people to our ER, wonderful results that Brenda was talking about, 90 minutes, that's wonderful. And so thank you for helping me as I come to the ER to be with families of patients that you bring to us. Thank you for helping me become and continue to become who I am. And I hope in this season, you will take a minute sometime in your busy time to not only rejoice with your families and be thankful with your families, but to think about who helps you, including the other people in the room, but who helps you become and continue to become who you are. So let us pray. Holy God, we thank you for these men and women who serve as first responders. First, we offer a special blessing for those whose watch ended this year. But we are grateful that all of these persons are prepared for whatever comes, for they never know what awaits them. Help them to stand strong. Fill them with courage. May they have compassion for those whose lives are broken. May they always find security in you. May our community to support and care for them. Forgive us when we forget to say thank you. We pray also for their families who experience stress and anxiety as they so generously share their loved ones with us. May these men and women have time with their families this season. Thank you for these men and women who rush in where we run from. Bless and keep them this day and every day. Amen. Thank you.
Thank you very much. Next is going to be Jackie Martin with our trauma report.
Thank you. Okay, so I will tell you that I had a hard time finding a couple runs, which is a good thing. Things went really well the last couple months, and then I said that, and we had a couple pop up, but that's okay. That's all right. All right, remember I like interaction, so you got to talk too. Okay, case one. So the two cases I picked because they were, one, true trauma, and two, both of them had a little bit different circumstance to them. So this guy actually walked into the ambulance service at 17:18 in the evening. Not totally uncommon. You've had that happen, right? That's not totally out of the blue for that to happen. So they got pretty busy with him and left station at 17:17, and they got to us at 17:47. And so this was not obviously a local station. This was really good time considering where they're coming from. So scene time, I guess you call it scene time, is 9 minutes. So from the time he walked into the station until he arrived in the ED is 29 minutes. I have driven this. I will tell you on a normal lazy day, it takes me 40 minutes. Okay, so this is really good time. So he was driven to the ambulance service by his wife after he crashed his ATV going about 30 miles an hour. So not only did she drive him in after he crashed, but he had to get it out of the mud and the woods because nobody else with them knew how to manage the ATV. So injured, he gets the ATV out, they load it, I think, and then drive in, okay? So she brings him into the ambulance service. He is in acute distress when he shows up. He's using accessory muscles. He's guarding his left lower abdomen. He's very tender in the pelvic region. Breath sounds are diminished on the left. He really has done a number to himself. He does have a respiratory history. He's got emphysema and he's had a cardiac stent. Other than that, he's a pretty healthy guy. He does take some home meds and he is allergic to sulfa. Vital signs, they did a really good job maintaining his vital signs, but we do see a pattern, and I've talked about this many times. And what pattern are we starting to see? Yeah, his tachycardia, his pulse pressures are coming together. Look at his O2 sets. Okay, significant impact with this ATV. Like if I remember right, I'm looking at Polly. For some reason, I think he may have rolled it even. I can't remember the whole story. Yeah. So they put him on a monitor, he's sinus tach, they put him on 15 liters non-rebreather, they increase it up, they get a couple of IVs going, they give him an albuterol treatment, and they put him in a C-collar. He's alert and oriented, still using those accessory muscles, guarding his belly, he's tender in the pelvic area, breath sounds are diminished. Initially, short sentences, sat in 90% when he come in the door, because some time has happened. Okay, he's in, I'll tell you, it's Park County, he's in the middle of nowhere, on an ATV, and anybody that knows Park County or works Park County, there is no easy route to anything, right? You got to get out of the woods, get to a road, get to a highway, then get to the ambulance service. So we get him here, we call a level 2 activation. We do upgrade it to a level 1 when he gets here because the charge nurse looked at him and said, oh, and up to a 1. Physician assessment was very limited because he was in such severe distress, but they did do a good job assessing him. He has a left pneumo that's moderate in size. He's got 4 rib fractures, and he has an acetabulum wall fracture. So he really impacted when he flipped that ATV. So we put a chest tube in the ER. The trauma surgeon put a chest tube in. We admit him to ICU under trauma. We do some PT for some non-surgical fractures. Day 2, he comes out of the unit, goes to a regular floor. It's not until day 7 that we can pull his chest tube. Day 10, he's got some nausea and vomiting, which actually delays his discharge. At this point, we're thinking about sending him home, but he's so sick that he can't go home. So now we start looking for some other problems. So on day 13, he gets a scope. We find out he's got pyloric stenosis, he's got strictures, he's got erosive esophagitis. He's throwing up on day 10, so chicken, eggs, not sure. He's got some peptic ulcers going on, and he doesn't get to go home until day 15. We were looking at going home on day 10. So, thoughts? What do you think? It's a good run. It's a really good run. But was there anything we could have done a little better in or out of the hospital? Come on. I see your faces. You've got comments. I don't remember who the ED doc was. Was there anything we could have done any better? They did bypass Clinton.
I think I read this run, but I don't remember. Did they note wheezes or anything?
I don't remember wheezes. Misty's giving me a no. Polly's giving me I can't remember. I don't remember wheezes. I remember diminished, but I don't remember wheezes. And I don't remember which Lynch dropped the chest tube. I think it was one of the boys.
I was just curious about that.
I think you're right. Yeah. I mean, it was a good run. There was extended time between the accident and care because the old boy was an old farm boy that was going to take care of his equipment before he got help. And I'm sure that probably took a lot of convincing to do. Okay. And then he had to get, like I said, transport to the, actually they were on their way to the hospital. And she said, this ain't happening. You're scaring me. We're going to stop at the ambulance service. And when they did, he was in all kinds of distress. So. Maybe. Yeah. Well, and he had a respiratory history, and I'm sure that probably influenced the decisions because they gave him an ebb treatment, and SATs weren't coming up because he had a big old pneumo. Well, it was a good run. It was a really good run. All right, number 2. This one, they get called for a person covered in blood. I love dispatch. Not really. I used to dispatch. Come on. Number 1 rule of dispatch is you know where your people are at. Okay, just saying. So the 911 call came in at 15:13. They were not dispatched till 15:16. That's a little long. I don't know what was going on there. En route at 15:16, on scene at 15:22. At the time, I do know the ambulance had to take a little whirligig to get to where they're going. There wasn't a direct route. They didn't get to their patient at 15:27, and when you put the pieces of this together, you'll understand why that is not a bad thing, okay? They left scene at 15:46, and they got in the ED at 1600. So 911 call to arrival in ED is 47 minutes. Their scene time was 24. This is a 53-year-old male that attempted suicide by lacerating, I think it was both of his wrists, and he just about did it. So here's your vital signs. So when they first get to him, he's only alert to painful. His pressure is kind of in the toilet. He's tachycardic. Respirations are not very good. SATs are at 98%, but we know that's not always the best choice. And Glasgow's at 4, okay? And I mean, when they say covered in blood, he is covered in blood. So they actually bolus him a little bit and bring it up, put him on some oxygen, but he's still a little tacky. It's a significant jump. That one, I don't know. I don't know. I have no thoughts on that. So they can't get an IV in place because he has bled out. So they do put an IO in the left tibia. They give him about 300 cc's of saline in a pressure bag. He remained unresponsive and diaphoretic at this point. This is a textbook hemorrhagic shock. So the original call to EMS was for the person covered in blood. So they had to walk a significant distance to get to this patient, okay? Patient was found lying in bed covered in blood. Bystanders tell him that it's a self-inflicted wound. There's a makeshift tourniquet in place. They use a rope to make a tourniquet. And they did try to apply some bandages. So there was at least some bleeding control going on here. So they have no idea when he did it. I'll just tell you, it's a federal prisoner. Okay, so getting to him was horrible. I was a little surprised they didn't have a tourniquet at the pen. They used a rope. So I would think they would have the tourniquet before they would have the rope, but who knows? That's just my thought. I'm a civilian. So anyway, so he did cut both of his wrists. So EMS noted that there was some clots on the floor. There was about 1,000 cc's of blood on the floor and on the bed. They did try an EJ and couldn't get it because he has no veins. Medic notes seizure activity en route. We get him here. We notified of the trauma alert via iHearn, so everything went well there. We did activate a level 1 at 1600. Our docs were at bedside at 1606. I'm guessing they must have been in-house. Blood bank was at bedside at 1607. Radiology was at bedside at 1607 as well. Because remember, with a level 1, you get the cavalry. You get everybody and their brother, sometimes too many people. So the patient was non-responsive when he got here. Vital signs for us were 73 over 53. That makes a little more sense. I'm not sure what those other two were. 100% on 2 liters. Glasgow still 7. So we give him warm fluids, warm blankets. We raise the temperature of the room because what happens to patients when they go into trauma and when they're bleeding out, right? Their body temperature will plummet. We do initiate the massive transfusion protocol. He got a total of 4 units transfused. He was intubated in the ED and we took him straight to OR. He did have an ulnar artery and a venous injury, both to his wrist. After OR, he went to ICU. Hemorrhagic shock resolved. Now I know which Lynch was on it. Hemorrhagic shock resolved with control of bleeding and the blood transfusion. He did stabilize. He did tell the nursing staff that he was going to do it again, but he promised he wouldn't do it in the hospital. And we sent him back to the pen on day 11. So knowing the circumstances, what could we have done better? What was done well? What are your... When did he get his central line? He did, and I honestly cannot answer that. Do you remember, Polly? He had an IO coming in the door, and we intubated him at ED. I don't know when the doctors, no, he didn't. In ED? Okay, so that I would just about guarantee you that was placed by trauma. Don't you agree? I'm looking at you, Dr. Bossy. Yeah. Trauma probably placed the central. Yeah. Okay. It is perplexing that prison would have. They used a rope. It shocked me that one, they had a rope. Evidently not. That's on my to-do list actually to talk to Barry, because I would have thought if anybody had it. Of course, they still have ported IV tubing too. You still have to use a needle in their IV tubing. So you would think if anybody needed needleless, it would be them. No, they did not have a tourniquet. They used a makeshift tourniquet with a rope. I think that's probably a good idea for Barry and I to do that next year. Although I have been in the prison once when I worked on an ambulance. It's with a very old medic. And when we come out, I said, I'm never going back. And I have not been back to that day. So when they look at you and say, you're expendable. If anything goes down, hit the floor, cover your head, and pray that you don't get hit. I was like, I'm never going back. And I have not been back. Medic 9 did respond to this, but it was when First Street was down, or 63 was down. So they had to go around. So as far as times, I think everything was good. You know, I mean, the dude wanted to die, and he just about did it. So, all right.
Thanks, Jackie. Next up, Dr. Fishwell. We'll talk about neuro.
Okay. So I'm just talking about the EMS people, like
Yeah.
I'm not addressing
Nope.
specifically EMS.
Yeah.
Okay. Good morning. I'm Dr. Vishwas. I'm the stroke director for Union Hospital. So I'm going to talk about some of the guidelines and then the recent guidelines and that are changed for the acute stroke management, and what we do here in Union as a primary stroke center, and going forward, what our goals will be. So in this talk, I'm talking about briefly about the different types of stroke and what are the recommendations we have and stroke protocols. Some of the stroke assessment tools for the EMS personnel, and then what stroke assessment tool we use and what are we looking for if you want to go for the comprehensive stroke center, and pre-notification and stroke treatment. So as you all know, a stroke is a medical emergency, and it occurs when the blood flow is either cut off or it is reduced, depriving the blood flow to that part of the brain, which eventually dies and causing the symptoms. And symptoms can occur on a different part of the brain which is affected, whether it is on the left side or the right side. And we'll talk more about what are the main symptoms that we look for in patients with stroke. There are approximately about 795,000 strokes occur in the US each year, and it is considered as the 5th leading cause of death in the US. And it is the leading cause of adult disability, as it causes more weakness, or it may cause some cognitive dysfunctions, and also contributing factor for some of the dementias as part of vascular dementia. On average, every 40 seconds, someone in the US is having a stroke. Over 4 million stroke survivors are in the US, and the cost of stroke is pretty high, but it's about 38.6 billion, which is either direct or indirect cost. So there are mainly 2 different types of stroke. One is the ischemic stroke, which is typically caused by a blockage using either a thrombus and in an artery, which stops the blood flow to the part of the brain. Typically, if you see 87% of the strokes are ischemic, and most common types of strokes occur in the anterior circulation. We have both anterior and posterior circulation. The anterior circulation comprises of internal carotids and then the middle cerebral artery, anterior cerebral artery. Majority of the strokes occur in the anterior, but also the posterior circulation strokes are common too. There are 2 major etiology which causes these type of strokes. One is the embolism and another is the thrombosis. Embolism is one of the more common cause of the stroke, whether in a blood clot or a plaque fragment, which can be come from the arteries, which is arterioembolic, or it can come from the heart if there is a thrombus in the heart causing the cardioembolic strokes. The other one is a thrombosis, wherein the blood clot is formed in the artery, which can be in the middle cerebral artery or in the ACA or different parts of the artery, causing the stroke by depriving the blood flow. The second type of stroke is the hemorrhagic stroke, which is about 13% of the strokes that happen due to hemorrhage. And most commonly, it's the hypertension, which is the leading cause of the hemorrhagic stroke. It is due to any breakage in the blood vessel within the brain. It can also happen due to a rupture of the aneurysm or the trauma. Typically, a rupture of the aneurysm or trauma would cause the subarachnoid bleed, whereas the hypertensive bleeds tend to be more intraparenchymal hemorrhage, which is in the substance of the brain. So intraparenchymal hemorrhage is within the brain tissue, and we also call it as intracerebral hemorrhage, and hypertension and amyloidosis are the most common cause of the intraparenchymal bleed. There can be amyloid angiopathy as we in the elderly patient that causes more of a intralobar hemorrhage. Then we have a subarachnoid hemorrhage, which happens when the blood vessel bursts near the surface of the brain and the blood starts pouring out outside of the brain, but between the sulci, which is between the brain and the skull. Then we have a third entity, which is a TIA, transient ischemic attack, which we commonly refer to patients as a mini stroke, which is not a mini stroke, but it is a kind of like a warning sign for a stroke to happen. So it produces stroke-like symptoms, and previous definition was any stroke-like symptoms which resolves within 24 hours. But with the new emerging techniques and with the advent of MRI, any stroke symptom with a negative MRI is considered as a TIA. There may be a stroke in which a patient develops weakness and it improves within 2-3 hours, but if he has a small stroke on the MRI, we still call it a stroke and it's not a TIA. So the definition of TIA has changed. The MRI kind of now makes the diagnosis whether it is a TIA or a stroke. So TIA is also typically caused by a clot, but unlike stroke, the blockage is temporary and usually the blood flow is restored. There is no permanent damage to the brain. And we use a scoring system called ABCD2 score, which kind of helps us determine which patient is at higher risk of having stroke in the next few days. Approximately 15% of all the strokes occur after TIA, and TIA is a medical emergency because we don't know whether this is an evolving stroke or is it TIA. So we have to treat it as a stroke, and we do the TPA for these patients if they're having a higher NIH stroke scale. So what are some of the common stroke symptoms? So some of the common stroke symptoms depend on which part of the brain is affected. So it can be a right hemisphere or a left hemispheric stroke. Right hemispheric stroke, typically, these symptoms are from the middle cerebral artery stroke symptoms. They will have slurred speech or dysarthria, weakness or numbness of the face, arm, or leg, causing hemiplegia or hemiparesis. Then they can have left-sided neglect if it affects the parietal lobe of the brain. Then they can have right gaze preference depending upon the involvement of the visual fields. Left hemispheric strokes typically is the dominant side of the brain, which causes speech problems like aphasias. Typical aphasias would be wherein a person will say like, hey doc, I wanted to speak something, but I was not getting the words out. So that's what a typical motor aphasia is. They want to speak, but they cannot get the words out. Their fluency is affected. That is one of the most common symptoms that we come across in patients with stroke. Whereas the other type of aphasia is they're able to talk, but nothing makes any sense. So the fluency is not affected, but their comprehension is affected, where they talk, but nothing makes sense. If you ask their name, they might tell you something else. If you ask them the date, then they might tell you something else, which is most commonly sometimes people think that they're confused. It's not that confusion. They know that they're talking, but they don't know what they're talking. They can have the weakness and left gaze preference. And brainstem stroke symptoms are the posterior circulation strokes because the brainstem receives the blood flow from the vertebral and basilar artery system in the back. Usually they present with acute. It is a very acute onset of nausea and vomiting is very intractable vomiting, and it's protracted vomiting, and they will have a very severe vertigo with it. We also have to, it becomes a very challenging in the ER when any person comes with vertigo, because the vestibular system can also cause vertigo, acute onset like acute labyrinthitis, and the BPPV can have a vertigo with nausea and vomiting. So we have to make sure that this is not a stroke. It's very hard to distinguish whether this vertigo is due to a stroke or any peripheral causes of vertigo. They can have speech problems. Typically, that would include the dysarthria. They can have swallowing problems, and they will have abnormal eye movements in the form of nystagmus or ophthalmoplegia, wherein their movements of the eyes are affected. And decreased consciousness if it is affecting the top of the basilar artery in the back here, and they can have altered level of consciousness and acute onset of psychosis. And they can have crossed findings, means they can have facial weakness on one side, but the weakness of the arm and the leg on the opposite side. That's what we call it as a crossed finding. Typically, the stroke in the middle cerebral and anterior cerebral will have the findings on the same side, like the weakness of the face or the other cranial nerve weakness on one side and the weakness on the other side, same side. With the brainstem strokes, it will be crossed finding. Weakness will be on the left side, and then there'll be weakness of the arm and leg on the right side. The intracerebral hemorrhage, typically they will have a very acute onset of symptoms too, with most of the times associated with nausea and vomiting. They will have a very severe headache, and depending on the location of the bleed, again, they can have weakness and decreased consciousness. People with subarachnoid hemorrhage would come with the very, very severe headache and would often say, like, this is the worst headache of my life. And they can have neck stiffness or pain. And sometimes the CT head will show the bleed. And sometimes if the CT head is not showing any bleed, and if there is high suspicion that this may be subarachnoid, then we do the lumbar puncture to look for any xanthochromia or any blood in it, which will differentiate the subarachnoid hemorrhage. So, well, not all the difficulty with speech and not all the weakness are due to the stroke. There are several conditions which can mimic the stroke, where a person with alcohol intoxication can come with symptoms of slurred speech, and they can have confusion, and they can have altered level of mental status, which kind of makes us think there may be some stroke going on. And cerebral infections, especially meningoencephalitis, can have stroke-like symptoms. And again, drug overdose and toxicity again presents with dysarthrias, epidural hematoma. Hypoglycemia is one of the common conditions that can also mimic the stroke. That's why before giving the TPA, we have to make sure that the patient is not in hypoglycemia, and if it is, we have to correct and then decide whether a person is eligible for any treatment. Other metabolic disorders like acute kidney injuries or uremia or hyperammonemia can all mimic the stroke. Migraines, yeah, we do get a lot of migraines, like complex migraines. They can have speech problems like aphasias, or they can have numbness of the face, numbness of the arms and legs, and even they can have vision problems. And they're the tough ones to differentiate between the stroke, TIA, or the migraines. Bell's palsy, we just had a patient with Bell's palsy who ended up getting a TPA, but he also had some focal weakness, which was not sure. So Bell's palsy is it just affects the face. It does not affect the upper and lower extremities, wherein the lower half of the face is affected and the upper half of the face also is affected. Whereas with the face affected due to the stroke, it's only the lower half of the face which is affected. Seizures and post-seizures will typically cause the weakness on one side. So if there is a seizure at the onset and then have a weakness, it was a contraindication for TPA before, but now it is a relative contraindication for TPA, so we have to be careful. We do still do the TPA if the high suspicion for the stroke rather than a seizure. Then brain tumors and hypertensive encephalopathies can all mimic strokes. Any questions on these stroke mimics? Okay, so the EMS policy recommendations. The EMS people are the main people who are running the stroke here because they are the ones who are involved in the initial with a patient encounter, and they are the ones who are identifying whether the patient is having stroke symptoms, and if they have, and they are the key people in the management of the stroke. And the stroke treatment starts from you guys, from the EMS people. The stroke treatment starts from there and their notification. So typically it starts with supporting the ABCs and then pre-hospital stroke assessment. We will discuss about that. And then establishing the time when the patient was last normal. So this is a very, very important piece of information, which most of the time the patient or their family are not able to provide much because that drives the treatment. If the patient was last normal is less than 3 hours or 4.5 hours, then we can do the TPA for them. If it is more than 4 hours, then 4.5 hours, and then they're within 24 hours, then they are the ideal candidates for thrombectomy or any other intervention. Then it involves the rapid transport to the nearest primary stroke center or comprehensive stroke center. And sometimes EMS can bypass the hospital, which does not have stroke resources. And if the stroke center is within the reasonable transport range, so they can bypass the hospital and can come to the hospital where they have a stroke facilities like either primary or comprehensive stroke center. They need to alert the receiving hospital as soon as possible of potential stroke and initiate called the code stroke. And it is always better if they check the glucose level while at the scene. If they are hypoglycemic and if they are treated, by the time they come to the ER, their glucose will be corrected, so we can better assess the patient for the stroke. So these are some of the policy recommendations that were given by American Heart Association and American Stroke Association. So the goal of the stroke care is like every second and every minute in the stroke counts, because every second or every minute delayed, there is several number of neurons that die because of the lack of blood flow. So the stroke chain of survival, it also links to the actions that are to be taken by the patients and then by the family members. So typically this how happens is the family member or a bystander notices the stroke signs and calls the 911. EMS rapidly arrives at the scene and they perform the stroke assessment. And EMS rapidly notifies receiving hospital that patient is arriving and initiate the code stroke, and hospital rapidly diagnoses and treats the patient. So these are like the common steps involved in the stroke management. So there was an article published in the Neurology Journal which reduced the in-hospital delay to 20 minutes in stroke thrombolysis, which was mainly due to they did a study in what was causing the delay in doing the door-to-needle treatment. Now the door-to-needle treatment is like 60 minutes. That is the primary goal, 60 minutes for at least 75% patients. And the secondary goal is 40 minutes in at least 50% patients. So in order to achieve that, we need to have a very efficient EMS personnel, and their role is very important, like how quickly they bring the patient with all the stabilization, and their quick assessment by using the pre-hospital stroke assessment tools. So this study showed that it reduced the hospital delay to 20 minutes, and it was mainly the necessary measures taken by the EMS people. So these are some of the steps that are the measures that were taken going by the year in 98. They realized that it was very important for the EMS involvement to reduce the time, and that was initiated in 98. And then in 2001, hospital pre-notification, and the rest of them are like, as we all go by, there were so many things which were involved. So the differences between a primary stroke center and a comprehensive stroke center. So we Union are the primary stroke center, where we stabilize and provide emergency care for patients with acute stroke. We assess the patient whether they are candidates for the IV TPA, which is the gold standard treatment for the acute stroke patients who are within 3 to 4.5 hours of symptom onset. So we do the TPA and then we admit, and if we think that this patient needs a intervention like mechanical thrombectomy, then we send the patient to comprehensive stroke center. The comprehensive stroke center have the capability to support all needed level of care for stroke patients. They have interventions. So the closest comprehensive stroke center we have one is the Indianapolis, the Hayu Health Center in Ashkenazi, where they do the mechanical thrombectomies for us. So the map in the first map shows the number of primary stroke centers we have all over the US, and the second one is the comprehensive stroke centers, but these numbers are growing. So let's talk about the stroke assessment tools. These tools will help the EMS people to identify the people who have had a stroke or at risk of who can be benefited by using the TPA or transferring them to comprehensive stroke centers. So these are the field stroke triad scales. One is the RACE, that is the Rapid Arterial Occlusion Evaluation Scale, and the Cincinnati Pre-Hospital Stroke Severity Scale, which is widely used, and I think that's what we are using, and Los Angeles Motor Scale, and VAN is the Vision Aphasia Neglect, which is becoming more and more popular and widely used now, and there is Fast ED scales. So this is the Cincinnati Pre-Hospital Stroke Scale, which is commonly used like one, you look for the facial droop. The normal one is that make sure that the left and right side of the face move equally. Abnormal where the nasolabial fold will be absent and they don't move at all. Then there will be arm drift and look for the abnormal speech. Abnormal speech can be slurred speech, or it can be difficulty using the words or difficulty speaking, or it can be difficulty with comprehension. This is the Los Angeles Pre-Hospital Stroke Screen, which uses a little bit, it has 5 points in it. One, patient age over 45 years gets 1 point, and no prior history of seizure disorder, and new onset of neurological symptoms in just 24 hours. So this is not very specific. It kind of uses all the new onset neurological symptoms, and then again, look for obvious symptoms like facial droop again, like the facial smile or the grimace. Then look for the grip, whether they have a weak grip or no grip, and then the arm weakness, and whether patient is able to ambulate at baseline, and also the blood glucose. This scale was not like very specific, but used could cause there can be like the stroke mimics that we talked can also cause some of these symptoms. So the Miami Emergency Neurological Deficit Scale, which uses the mental status, wherein we use level of consciousness, which is AVPU, that is alert, and then alert to verbal response or the painful stimulation, or whether the patient is unconscious. That's the AVPU scale. And speech, and then you ask the questions, so it's the age and the month and the commands. And for the cranial nerves, a person would check for the facial droop. The best way of checking would be like asking the patient to smile and see if you see any asymmetry in the face, and then look for the visual fields, and then the horizontal gaze, like movement of the eyes. And if the eyes are restricted and they're not moving side to side, that's one of the signs. And then in the limbs, you would look for the arm drift and the leg drift, and then in the sensations and coordination. This is more of a comprehensive evaluation rather than a quick or a fast assessment of the stroke. So the most commonly used, and what we are using, is the Cincinnati Pre-Hospital Stroke Scale, which is the facial droop, arm drift, and speech, that is the FAST, F-A-S-T scale. The VAN scale, that is the Vision Aphasia Neglect, is more specific for the anterior circulation, where you look for the vision affected, and then the aphasia, like any, as I said, the motor or the sensory. And if a patient has neglect, If the patient has all of them, then they are assessed for the TPA and also for the thrombectomy, and they need to be transported quick. So any questions on the scales? Okay, so this is the pre-notification systems that are used by the EMS. So the EMS professionals, they kind of assess the stroke patients with the scales that we discussed, and we typically use the Cincinnati scale, which is the FAST score. And we are planning to see if we can implement the VAN scale, and that is not implemented uniformly everywhere. So we are working with IU and see if we can implement the VAN scale, which would be. We have it on ours now. We have now? VAN scale where everybody's doing VAN positive. VAN now? Mm-hmm. Yeah, because last time they said the IU said they are not using it. Yeah. Yes. Mm-hmm. Because the VAN scale will be very helpful in identifying the large vessel occlusion, and that will help us determine whether the patient needs thrombectomy so that we can quickly do the testing we need to do in the ER. I think most of the stroke centers are going towards the VAN scale. So the EMS professionals notify the hospital staff that a stroke patient is being sent, and then it also helps improve the rapid triage, evaluation, and treatment of patients. Because the sooner the patient gets to medical treatment, there is greater potential for a better outcome. So most of the times we are now going, some of the centers going with the stroke mobile units where you have everything in the ambulance, like I think IU has one, where I think it's Indianapolis downtown, like where they have a stroke mobile. Where there is a CT scanner, so you have a stroke patient, you assess with the VAN scale or the FAST scale. If you think he's a candidate, then you do a CT scan in the ambulance, and then if it is negative, you do the TPA. So that would be the future of the stroke that we are kind of looking into, having the stroke mobiles. So this is the treatment protocol that we typically follow. The EMS notifies the hospital, and then the patient is brought to the ER. If the symptom onset is less than 3 hours, and now there are certain indications for the 4.5 hours, 4.5 hours, and we go through the checklist whether the patient is eligible for the TPA or not. So if they're eligible, then we do the CT scan, and if the CT scan is negative, we do the TPA, and then after the TPA, we do the CT angiogram of the head and neck with perfusion. And if there is any evidence of there is large vessel occlusion, typically in the anterior circulation, we send them for mechanical thrombectomy. If a patient comes with symptom onset more than 3 hours or 4.5 hours, but less than 24 hours, now previously it was, they used to say 9 hours and 12 hours, but the recent study published, they looked into 24 hours for doing the mechanical thrombectomy in these patients who had stroke symptoms. So now we consider the interventional treatments if they are more than 3 to 4.5 hours, but they're less than 24 hours, we do still consider for thrombectomy. So it is still an acute stroke code if they're less than 24 hours. So these are the treatment options we have for the stroke. One is the medical management, which is the IV TPA, which is the gold standard for the stroke treatment. Patients must be within the time window that is 0 to 3 or 3 to 4.5 hours. That's why it's very important for us to know that one question will decide, last time no normal, will decide whether the patient is eligible for TPA or not. Well, there is always question, people ask me like, how do you decide when the patient wakes up with a stroke? So we don't know. He was last known normal was when he went to bed, but he wakes up with a stroke. Well, we don't do TPA for them because the stroke can happen at any time. But there is a study going on, which is called Wake Up Trial, and they're doing it in Pittsburgh. What they do is they do the MRI, a quick MRI, and based on the MRI findings, we can still do the TPA for them, but it is still under, still in the study. It is not FDA approved or it is not completely approved. A lot of university settings, they are doing the wake up strokes. Some of them are eligible, so, but in our situation here, we don't do TPA for the wake up strokes. Intra-arterial thrombolysis is a mechanical thrombectomy technique, which is typically FDA approved for the anterior circulation. I have had some interaction with the IU physicians who are also considering doing the thrombectomy for the posterior circulations. We had a couple of patients that we sent. They did the thrombectomy for the vertebral and basilar arteries, which is not FDA indicated, but the results have been good, which will be in the future. We'll be seeing a lot of that coming. So that will be more of a clot retraction, and it will be administered up to 6 hours after stroke symptom onset. That is the FDA recommendations, but based on the recent study that was published, we can, most of the comprehensive stroke centers are doing up to 24 hours. How we decide that? We do the CT perfusion and see whether there is any salvageable brain tissue, or we can see the brain tissue, there is a lack of blood flow, and which is at high risk of going into completed stroke, but it is not completed yet. So there is some salvageable tissue that by doing the thrombectomy, we can save the brain. And the mechanical thrombectomy is the one where they go in and either they lyse the clot or they retract the clot. And that can be, it's up to 8 hours from symptom onset, that is the 24 hours. And intra-arterial thrombolysis is, it is still 6 hours after the stroke symptom onset. What I meant was the mechanical thrombectomy is the one which is for 24 hours. Have any questions on that, or any questions on the treatment options? Okay, thank you.
Very much.
Thank you, sir.
Thank you very much. The next presentation is going to be Chris Thomas. He's got a case presentation for us. Put it on your shirt or something.
Okay, this one's pretty straightforward, but Barry asked me to do the presentation on it, so here we go. So it was October 26th. We were dispatched on an unresponsive male, dispatched at 13:09:20. We actually had a pretty quick response time. We were already out on the air, so we were able to get there pretty quickly. Had to cross 2 train tracks on the way, which surprisingly were not blocked. So we got there pretty quick. When we arrived on scene, we were presented with an adult male that was on the ground, unresponsive, apneic, ashen in color, CPR in progress by bystanders. Well, kind of, I guess you can call it chest compressions. He was very uncertain about what he was doing because the patient had agonal breaths, so he wasn't really sure if he needed to be doing compressions or not. A lady was at his head, had a head tilt chin lift going on. When I walked in, she said, he's agonal, but I feel a weak pulse, and she could tell I was like, you know the lingo, what's going on? And she's like, I'm an RT. I said, okay. And she's like, he's got a weak pulse, I think. And I'm like, I don't think so. So we got down there, and of course, he's in a bedroom, and he's in the most inaccessible part of the bedroom possible. He's on the far side of the bed. We've got about 18 inches of room to work with. So we had to get him out onto the other side of the bed where we had a little bit more room. And we were able to do our complete assessment. He had no pulses, get him on the pads to do a quick look on him. Did find him to be in VFib. This was an unwitnessed event, but I'll get to that on the next slide. So he had no central pulses. His skin was still dry. It was warm, again, very ashen in color. And so the wife basically says that the patient had been complaint-free throughout the day. They'd been out shopping, they had lunch. She did advise us that he had a triple bypass earlier in the year, no complications from it, has had no issues since the bypass. They got home, she swears up and down they weren't home even 5 minutes before she went in and found him face down on the bed. She went next door, like they always do. They go get the neighbors first before calling 911. So she went next door. A family dentist lived next door. Makes sense to me. And went and got him. They come over, which was helpful because she was unable to move him off the bed. So they were able to get him off the bed onto the floor. She called 911, EMD'd him through doing chest compressions until we got there. So the actual downtime we think was somewhere before CPR got started was somewhere between 4 and 6 minutes by the time she went and got help, got them back, and was able to get him down and start compressions. So we were providing continuous chest compressions, obviously. We were delivering electrical therapy once we recognized that he was in VFib. Airway management initially included placement of an OPA, BVM ventilation before, or until rather, I could get him intubated. IO and IV access was established. Crystalloids were provided wide open. So other treatment throughout the arrest included a total of 7 unsynchronized shocks in ascending order. He would briefly transition to an organized rhythm for about 4 or 5 complexes before degenerating back into VFib. Epi was given, we actually only gave 1 milligram of epi throughout the code. We were focused more on termination of the arrhythmia. He got his amio bolus in between the shocks as indicated, and then we achieved ROSC at 13:27:54. So that was a total downtime for us from patient contact to ROSC of 13 minutes and 29 seconds. Almost immediately upon achieving ROSC, he started to have spontaneous respirations. He was breathing somewhere between 15 and 20 times a minute, but he was still completely unresponsive. Didn't even respond to pain, no withdrawing or anything like that. We also did check his pupillary response. He had brisk pupillary response, so that was promising, obviously. Immediately obtained a post-ROSC 12 lead, so that's pretty much what we got. Degenerated into a wide complex tachycardia with pulses. So subsequently, we provided synchronized cardioversion to him at that point. These were his vitals just prior to the cardioversion being administered, heart rate of about 140. His respiratory rate I have there is 8 to 10 spontaneous, but it was actually a little higher than that. He was satting well, BP was 92/60. We provided the cardioversion at 100, and it was a return of an organized rhythm rather. At that point. So all things were looking up. His color improved dramatically. His color improved actually while we had compressions in progress once he was obviously being oxygenated. So once cardioversion was provided, this was his post-cardioversion 12 lead. Anybody who knows how the LifePak 15s work know that the computer will automatically print a new 12 lead anytime it senses a rhythm change. By the time we got to the hospital, I think we had like 22 EKGs because it just kept changing. The morphology of his complex just consistently changed. He was a diabetic, so we checked his sugar. It was normal. It was like 180 something, nothing big there. Still remained completely unresponsive for us. His spontaneous respiratory effort continued in the mid-teens. Pupillary response was still brisk and normal. Had an amio infusion going. Did serial EKGs, not even by choice. They just kept printing themselves out, so we had no problem with that. Maintenance fluids, didn't have to bolus him anymore. Popped him on our vent for transport. Again, after the cardioversion, his BP returned to normal limits, had no issues with his blood pressure. He did not require any pressure support. And like I said, really only got the 1 epi during the actual code. SATs remained great. Titrated him down to 60% on the vent. He remained at 99%. And again, pupils were round, reactive to light. He did vomit a lot. I think he must have had like clam chowder for lunch. Luckily, you know, the ET tube was in place. The chest film at the ER didn't show any aspiration or anything like that. But I mean, we were scooping it out of him because the suction couldn't keep up with all his vomit that was coming up. So he did get some Zofran. After that, by that point, it was pointless. It was all over the floor. So at the ER, they continued the amio infusion, did their normal ER stuff, drew his labs. I know his ABG wasn't anything to write home about. His troponin was negative. Pretty much his labs were, you know, not bad for somebody who, you know, had CPR for 15 to 20 minutes. Cardiology was consulted. They decided not to take him to the cath lab. He did go into VTAC once more while he was still in the ER with a pulse. They sync cardioverted again, popped him out of it. No other major issues while he was in the ER. And then he was admitted to the ICU. Now, before I go to the next slide, so this was on a Saturday, and by the time Tuesday rolled around, which was my next shift, you know, we had all been discussing the likelihood. I mean, you guys know how it is. They die. I mean, you know, we prolong the inevitable. That's what we do in most cases when they code in the field. It's like a 6% chance of neurological survival. but he had promising signs. He had really great pupillary response. He had the spontaneous respiration. So I wanted to go on Tuesday and check on him. First, I asked Barry, I'm like, can you see if he's dead yet? He's like, no, he's not dead. And so I went upstairs and get off the elevator, and there's his wife, literally like, boom, there she is right off the elevator. I'm like, well, this will be easy. And so I'm like, how's he doing? And, you know, she's like, you saved his life. And I'm like, well, how is he? And she goes, well, he's awake. And apparently he woke up through the weekend. So this was a Saturday mid-afternoon. He woke up through the weekend, progressively became more responsive over the next couple of days, was shaking his head yes and no to answer questions, was trying to mouth words, following commands. He had no motor deficits. So that was good. He was still on the vent at that moment. She actually told me that she was just leaving his room because they were going to be taking him off the vent, and seeing how he did as far as that went. So that's pretty much what all that says up there. They were able to remove the ventilator. We went back up there a few hours later, about 3 or 4 hours later, and went down to his room, and he's sitting up watching TV. And he had a little bit of slowness in his speech, but everything was appropriate. He was conversing correctly. He knew where he was. When asked, does he remember anything? He said no. It's like somebody slammed the door in his face, and down he went. I guess it was the bed that got slammed in his face. Luckily, it was there and not the nightstand. So I wasn't able to find out a whole lot after that, but I do know he had a pacemaker defibrillator put in the next day and got a little bit of OT therapy. As far as like physical deficits, he had none. He was able to hop up out of bed, walk around, go to the bathroom without needing a cane or walker or anything like that. He was discharged later that week. I do know that later in the month, basically like 2 weeks ago, he did go in for a cardiology appointment, and they had found on his defib history that he'd actually had an episode of VFib, an episode of VTAC that his defib had popped him out of. But other than that, he's doing pretty well. And so I guess he's part of the 6%. So anyway, so I leave you with this. You only live once? False, right? So there's that. Like I said, short and sweet, pretty straightforward.
All right, guys, the last thing I've got, I want you up here, if you haven't, be sure and sign in. Also, there are changes to the dates for next year. We are going back to the second Tuesday of every month, the even months here, odd months at regional. The dates are there for you. If you've got the Zoom invites, I will be changing those dates today and resending them out. So if you get something from me, canceling something, just accept the ones that are for the second dates, for the due dates that are out there.